asking pharmacists to do way more and not really having the personnel to support them and being able to do that and not take anything off their plate. So I mean, we just don't have enough bodies that things are going to get worse. And how we're going to deal with it.
The whole healthcare industry is going to change dramatically in the next couple of years.
To chronic disease management and the preventative aspect of care.
AI can now understand the key clinical concepts of what's being verbalized in healthcare.
Welcome to Cherry Live. I'm Dr. Jordan Valrath, physician, entrepreneur, and Chief Medical Officer for Cherry Health. We're talking about Canadian healthcare. Join us as we speak to innovators, industry leaders, and people working to drive the health system forward. All right. Today we're joined by pharmacist and former registrar of the New Brunswick College of Pharmacists. Sam began his career in community pharmacy and operated multiple pharmacies over more than a decade ago. His experience also includes time in a drug formulary management role with Blue Cross, and since early in his career, Sam has been involved in a wide array of pharmacy, community, and volunteer organizations at all the local, provincial, national, and international levels. His extensive participation on boards, committees, and task forces has helped develop a keen and lasting interest in organizational governance matters. Developing on more than 25 years of leadership experience, Sam is now an independent consultant, providing a variety of advisory services to professional regulatory authorities, associations, and other organizations, including governance, planning, strategy, board relations, policy development, and leadership. Thanks, Sam, for joining us. Excited to have that pharmacy side of things on the podcast.
Hearing that intro, it all sounds pretty exciting, doesn't it?
It does.
The governance side, regulatory governance.
That's the fun part. What have you been working on recently? What's life been looking like? You're no longer clinically practicing, right? What are you actually working on recently?
I didn't hear it in that intro, so maybe it was my miss. But the last 10 years of my active career, I was employed with the College of Pharmacists, so the regulatory side of it. But the last few years now, I've been consulting since I've left that role. Consulting mostly around regulatory matters, governance, all various health professionals, that type of stuff, but not just restricted to that. And the last project that I've been working on, that I worked on, was for the Canadian Pharmacists Association, and it was about the recruitment and the registration of international pharmacy graduates. So how can we make their path easier to help meet the demand of the workforce? We're simply not producing enough pharmacists in Canada to keep up with the demand. And just like the rest of the world, we're fighting for that same talent. And Canadian Pharmacists Association wanted a little bit of insight on what could be improved and how we could get there.
And what was kind of the outcome of that? What is the plan? Are we going to be making it easier to bring in the IMG pharmacists, or what's the path look like?
Yeah, well, the path is very complicated, as I imagine it is for the physicians as well. We've got 10 different provinces with 10 very varied pathways to get the licensure, and they range in costs, from $6,000 to maybe a year to get licensed to the other extreme being almost 3 years and $20,000 to get licensed. So the IPGs, if they're paying attention and understand that there are different pathways, they'll take the road of least resistance, and they'll just simply transfer to wherever they ultimately want to be. But that's not a great system. So I think there's opportunity there for improvement. Unfortunately, I say unfortunately, I mean, it's an association only has limited influence on how it can change the pathways. They're owned by the regulators, as I used to be part of that group. So really, until the regulators are really ready to change pathways, it becomes a little bit more complicated. So CPHA was really looking at how do we support perhaps the IPGs in trying to get them across the finish line, prepare them for the exams, prepare them for mentorship opportunities, or perhaps find placements. We'll kind of support networking because they come to Canada, they don't necessarily know anybody, and it is very much about how you get placed or how you get those opportunities is who you know and who you meet.
Yeah,
so I think there's opportunity there for the associations to get involved in just plain support of these individuals. But I think there's also a need probably for some wholesale changes with respect to the pathways themselves. And there seems to be openness amongst the regulators about we need to revisit this. And again, there's competition and governments are starting to put pressure on some of the regulators about how do we do we make things a little bit better? We've seen the movement with the physicians and the nurses already right across the country, and I think it's just a matter of time until we see a little bit more movement with the pharmacists.
What's the scope of the problem in the pharmacy world? Because in the medical space, this is like one of the biggest things that we're just constantly hearing about and talked the most about is just like the practitioner shortage. Is it the same thing on the pharmacy side? Like we live in our own little bubble world and don't hear often a lot about what's going on in the other professions.
Well, I mean, it is. There's always, discussions. Is it a shortage of workers, or are we just not using the people that we have correctly? Well, tomato, I guess we're still wanting more people. Mm-hmm. And the reality is that the pharmacist scope and their involvement in care just keeps increasing. So we keep asking pharmacists to do way more, and not really having the personnel to support them and being able to do that and not take anything off their plate. So I mean, we just don't have enough bodies. Population is aging. Through the pandemic, pharmacists, they maintain their stores open, their pharmacies open throughout the pandemic, and they were the first point of access for a lot of people during that time, while sometimes doctors were, but doctors were sometimes harder to get a hold of. And through that, I think there was a certain recognition that pharmacists could take on more from a primary healthcare perspective. So governments are now even looking for pharmacists. I know through this work that I've done, I heard that, Quebec was looking to hire 200 pharmacists, for government positions. They're looking to put them in clinics at community level. So it's creating extra strain. But, the WHO predicted that by, I think it's 2030, we're going to be short 18 million healthcare workers. And that prediction was before the pandemic. So that number's probably gone up now.
So the expanding scope is not helping things. Like that's pulling pharmacists away from the duties where there's already an active shortage. Am I hearing that right?
Yeah, to a certain degree. I mean, part of it is because pharmacy maybe hasn't done a great job of backfilling, right? So moving the pharmacist to a little bit more of the clinical stuff, perhaps, that increasing scope, but then getting the technical functions done either through technology or through, pharmacy technicians or assistants. So I think there's part of that. So pharmacists often end up doing both roles. So I think there is a role to play, but even with just the scope continuing to expand, the more they offer, the more there's going to be demand for those services, right? So typically right now we're going with lists of what we call minor ailments. Well, those lists keep getting bigger, right? So potentially seeing more patients, then you need to have office space. You need to have appointments with these people. You need to have a structure, and that's not something that a lot of pharmacies they're getting there, but I think it's creating extra strain right now with all the extra demand.
What do the pharmacists think about that increasing scope? Like looking at it from the governance side of things, having a higher scope seems like a good budget decision, good business decision to try and get more people doing more stuff. I know like in the nursing world, there's been some pushback on the scope goes up, but the payment doesn't change. Right. It stays the same. And so they're feeling squeezed to do more with less. Like, what are the pharmacists like? Like the more of that autonomy, is that seen as a positive thing, or are they like, this is just more added onto the pile already?
Well, I think the latter is probably true to a large degree, because, the staff pharmacists, the frontline pharmacists, they're going in and they're putting in hours. So, I mean, I think if they were allowed the opportunity to do it well and to really own it, and not feel like, well, I got to hurry up and finish this with you, George, so I can go off and finish checking those 6 prescriptions and talking to the person about cough syrup in the aisle and answering the 3 waiting phone calls, then perhaps they'd be happier about it. I think right now it's creating a lot of stress. I don't know that that community pharmacy right now feels like a great place to be because of all the pressures. When I was still in my role, a lot of these services were not covered by governments, right? They didn't pay pharmacists to do this. So there was limited demand because there was not much profitability in it, right? So now the provincial governments, many of them are now paying for these services. And of course, the corporates and the owners, they want to build off of that, which just makes sense. So it's increasing demand, but they've got the same people, the same amount of HR to try to complete these extra tasks and provide these services. So I think it's creating strain. When I was in my role, it felt like not very many pharmacists were actually providing these services. There was a push to keep expanding it, but it's like, well, why would we keep expanding it when what's already enabled isn't really being used very much at the community level? But that's changed since government started to pay for it, and now it's really, I think, everybody's on a whole hog. And I think, and look, I think it's good. I think pharmacists can be involved in this primary care. They're an easy point of access most of the time, but there needs to be a balance with what do we give up if we're going to do this if we don't have the extra bodies to do all this stuff.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, chiropractors, dentists, and all other allied healthcare professionals can sign up for free and start checking out job opportunities from thousands of employers across Canada. We make it easy to advance your career with industry-specific job filters to help find your dream job or line up your next locum. You can also post jobs for free. That's right, if you're a clinic owner, manager, or a recruiting professional, you can recruit doctors and other healthcare providers for $0. There's no catch, hundreds of new health jobs posted every week. www.cherry.health to get started today.
Well, it makes sense, right? Like having more of that availability, more of that scope to actually care for your patients, right? Especially in like underserved areas, rural communities. I mean, there might not even be a doctor in that town, right? The pharmacist might be like the entire primary care team out in certain locations. It's interesting though that the pharmacists aren't looking fondly upon this. Like my picture of it was kind of the opposite. Like it was almost like, the sentiment is kind of like a pharmacists are taking our jobs kind of thing. But then from the physician perspective, they don't even want to be involved in taking over that primary care, it seems.
Well, I wouldn't go that far, Jordan. I think they want to do it, but they just want to be able to do it correctly and do it right and not feel like it's just another thing. Right?
Yeah.
I think they would gladly give up having to answer the phone 5 times, every 5 minutes, or having to check these prescriptions and do all these technical duties, and structure this in a way that, they can make appointments, they can take their time and talk with somebody. And, it's healthcare and even more so for pharmacy, but I think it's true in medicine as well. It's very transactional, right? Mm-hmm. So they get paid for in and out quick, right? They get paid for each prescription that gets done. They get paid for every patient that they see or prescribe for or what have you, right? So, I mean, it's very transactional. So there'll always be a little bit of pressure there to do things to sort of, keep things moving. So I think if they had a chance to do it right and to be independent in how they did it and manage their own workloads and all those things, I think pharmacists would absolutely love this. I think there's a different kind of pressure right now to say, well, we have to do it because it's part of our duties. Our boss expects that there might be certain targets or what have you, and it's creating extra pressure. And there's nobody doing my job when I'm not behind the counter.
Yeah, so they don't want to be like forced into doing things they feel ill prepared for. I guess that's part of the growing pains with systems reform.
Well, absolutely, and part of this was just the demands of the pandemic, right? Like I said, the pharmacists stayed open. They continued to provide services. In a lot of cases, there was extra strain on them and there was extra demand and extra precautions. And they came out of the pandemic pretty tired already, where they were already tired. Mm-hmm. And now this is building up at lightning speed. So it's just a lot to digest. They haven't really had a chance to have a breather and try to move things forward. And again, look, I'm speaking very general terms here. I would suggest and I would think that most pharmacists view this in a positive light, as far as, a big picture, positive light, but how is it impacting me on my day to day and how I feel and the pressure and all those things might be a little different.
Yeah, like the actual changes themselves are viewed upon favorably, but then there's sort of that corporate pressure and like chasing metrics and the business cases getting pushed down. That seems to be where that friction comes from. Absolutely.
I think as far as recognition of the role that pharmacists can play and that they can contribute to primary healthcare and support their patients better and all, I think that all helps the professional identity. I think that's all positive, but it's that back end of it that's a little, the business side of it that's a little little trickier.
Well, what's been the feedback, I guess, or what's been the reception like in the provinces where that scope has already expanded? Like, I think here in Alberta, we have one of the broadest scopes for pharmacists. Like, was it Ontario just recently made some more changes in that same direction as well?
Yeah, so Alberta is the leader in the country, and they've got a broader scope. You know, it goes beyond just the minor ailments that most provinces have now ushered in. But even then, I think there, you know, and I don't speak to pharmacists in Alberta very often. Even then, I wonder when I look at who's allowed to do it, and as far as the percentage of all the pharmacists, they're not all allowed to do it. I mean, you have to go through certain steps and get qualified for it and offered. So just the fact that, you know, not all of them have gone that way, maybe they already feel they've got enough on their plates, or they just don't want to go down that path. It's hard to know. You know, Ontario, you mentioned Ontario. They're actually one of the last provinces to sort of jump on this increased scope for pharmacists. So New Brunswick was, you know, near the front of the line, and you know, we passed, I think, in early 2010s, that you know, we began with our list of minor ailments that were allowed and all those things. But again, these things pick up momentum when somebody starts paying for the service, right? Yeah.
What needs to change, I guess, like in the ideal world, if you could wave your magic wand, like how would this be incorporated differently, or how would you make this smoother process with less friction?
Yeah, I think we're starting to go down that path in some provinces, you know, with the implementation of clinics where you've got, you know, your community clinics where you might have a nurse practitioner, a pharmacist, and a GP, or a mix of those. And you know, there's a little bit of triaging, right? So it's a little bit more like a health center, like a health clinic, and not necessarily a retail environment. And I'm not saying that what's happening in the retail pharmacy is not being done right, but it is a little bit of a different environment with respect to the structure there. So I think we're starting to see more of that collaboration at the community level, and I think that's the right way to go. Now, where exactly it's going to go or where it needs to go, I don't know, but I think there's, you know, in the past we've seen change where there was a focus on community clinics with, you know, multidisciplinary, and then when you think they're starting to take root, everybody's back in their offices after that, and there's no collaboration anymore. And then we seem to be returning to that collaborative model at community level, which I think is probably a better model, and I think will serve the community better, and I think is a better use of the various professional skills and talents.
So the College of Family Physicians of Canada, and just like all of the associations, there's been a big push for the team-based care, you know, the patient's medical home, where essentially, you know, everyone's working together in unison. And the, you know, common thread there seems to be that it's quarterbacked by the patient's family doctor. You know, they're sort of like leading the charge. And so it makes sense. But like the part of me that's like, you know, just trying to be humble, like what's the vibe from the other side of the table? Like, do they see the family physicians as that team quarterback, or are they wanting more of that like autonomy, more of that decision making? Like how do the pharmacists actually view that team-based care?
Yeah, I don't know that I can speak to that very much. I think everybody's open to that team-based care. I think it makes sense, and I think they would value being part of that team with their opinions valued and their input and their talents put to good use. So I think, I don't know if it's about who's quarterbacking or who's not, that's important. I think if people are truly working as a team and each recognize each other's strengths and opportunities, I think it can work, and I think there's certainly openness to that.
And then like that seems like it would be applicable not in that corporate setting, right? Like the pharmacists that are sort of like at the larger chains, they seem kind of removed from that team-based care. Like, will that wind up being like the minority of pharmacists wind up practicing within that collaborative team model? Or is there a way to actually get people connected and together on the same page, even if they're in that bigger corporate environment?
Yeah, so that's an interesting question. Where government has the ability to drive it and bring people into a team-based clinic, family health clinic of that type at the community level, and where those jobs and those roles continue to be attractive to pharmacists, right? I I think they'll continue to be able to staff those, and what will happen at the retail level is hard to predict. It depends
Yeah.
again on the bodies, right? I mean, if the good jobs, right, are at the family clinic level, if those are attractive because you're either working, 9 to 5, or you're working collaboratively, and there's not somebody timing you as far as how long it takes for each appointment, that kind of stuff, and you're getting paid equally or maybe better or what have you, then you might be in retail. Then you're going to continue to fill those positions first, in my opinion, and then the retail is going to be where it suffers a little bit, right? So I mean, that's sort of what you see when there's a crunch on the workforce. The good jobs, they get filled quicker, and there's movement, and people migrate to whatever they think is a good employer or a good situation. And then it's the ones that are the most stressful, or the most strenuous, or the most I don't know what adjective I want to put in there, but those are the ones that end up with really having the most difficulty to stay staffed.
What are those levers that the government and the regulatory bodies have to pull in order to enact these changes? Like the billing codes and the compensation structure seem like that would be a big influence, especially, I mean, across the board, not even on the bigger corporate places, but just how they actually structure that payment. Do they have any influence over the actual education side of things as well, and reforming like the actual programs?
I mean, there is and there isn't. I mean, we have, as the regulator, we like to think, when I was in that role, that everything starts with the regulator.
Yeah.
But the reality is there just continues to be a progression, right? And everybody's sort of trying to work in concert, and the regulators adjust to what the educators are doing, and vice versa. And the exam people, the competency assessors, they adjust it. And so it's a multi-stakeholder kind of dance, and who's leading, it's not always very clear. I think it sometimes depends on the issue. Even if we, as regulators, like to think that we ran the show, or think that we could. I don't know if that's true or not. But as far as creating that environment, I think the education and the scope of knowledge of pharmacists is already pretty high if you compare to what's happening globally with pharmacy. So I think there's a lot that pharmacists can offer already. I don't know that much has to change for the education. As far as the regulatory environment, that's moving pretty quickly to adapt to what governments want, which is more access to that primary health care offered through the pharmacy, or through the pharmacist, I should say. So I think that doesn't really have to change. I think the supporting structure of how that works in the community, how government is going to compensate, how they're going to set up the billing numbers, or however they decide to do it. I think that's the part that maybe still needs some work. But the reality is, I mean, look, there's some stuff through the pandemic that you work on for 10 or 15 years, and you think we'll never get an answer to this. And then, like 2 weeks into the pandemic, like, you've got a solution because it's critical. So at some point, somebody's going to decide it's critical enough and figure things out.
How much influence do those larger corporate entities have? Like, it's all very foreign again compared to medicine, right? Like the medical clinics, we've got the odd, 10, 12, maybe in Ontario, there's some with 20 or more facilities. But here in Alberta, it's largely one, maybe two, the odd 3, 4 different facilities. Everything's very independent, small, mom and pop. And then it seems as if like the actual lobbying side of things, or the medical association's influence on the government, is a little bit at odds. Like even here in Alberta, it's very antagonistic between the government and the Alberta Medical Association, and our like agreement and contract getting ripped up. So it seems like the influence in the medical sphere is more on the lower end. What's it like in the pharmacy space?
Well, I think the influence may not come from the associations all the time, at least what I know here in New Brunswick and from some of the smaller provinces, and it may be different in Ontario. So I'm not suggesting that the associations do not have influence, But what I am suggesting is some of the corporates are so big, and they create so much employment and so much revenue for the provinces, that I think they sometimes, they may bypass the association, right? So the link is directly between some corporates and government, perhaps, and there's influence there. And if that helps to develop the practice to a certain degree, that might be okay. But then when we've got conflicting, perhaps, goals or objectives, then I don't know how that plays out.
This show is brought to you by Cherry Health, Canada's medical network where healthcare practitioners connect. Physicians, pharmacists, dentists, chiropractors, and all other allied healthcare professionals can sign up for free and start checking out job opportunities from thousands of employers across Canada. We make it easy to advance your career with industry-specific job filters to help find your dream job or line up your next locum. You can also post jobs for free. That's right, if you're a clinic owner, manager, or a recruiting professional, you can recruit physicians and other healthcare providers for free. There's no catch, $0, hundreds of new health jobs posted every week. www.cherry.health to get started today.
We would be blowing that up a little bit higher. What are your thoughts on privatizing healthcare? I mean, your pharmacy space, it's largely privately delivered already versus medicine is mostly publicly delivered. Like, how has that played out in the pharmacy world? Do you think you guys are more up to speed, more up to date, further advanced?
Well, I don't know that we're further advanced, but certainly, I spoke earlier about governments not paying in New Brunswick for some of the services that were being offered. Well, pharmacists were still charging for it, right? If there was somebody willing to pay for it, they'd charge cash for it. So there was already, I guess, a certain degree of privatization there. Some insurance coverages, some of the private insurances will pay for some of these services. So I don't know. Pharmacy is an interesting beast, right? It's a profession with a cash register, and a profit-driven bottom line. And I think the tension between the profession and the business side of it is sometimes a little bit out of balance, and hard to see where things are going to go or where they should go. But I think the return, or the institution maybe, or the ability to have these family health clinics might help solve some of that to a certain degree. But I mean, that's a good question about the privatization. How does that work? I think right now it's not an issue because government's, agreeing to pay for most of these services.
Do those bigger corporate entities, just like on the topic of like accountability and metrics and KPIs, because you mentioned earlier that they have their targets and things that they're trying to hit for like prescriptions filled per day. Like in medicine, there's not a whole ton of that like KPI driven accountability, right? Like every year I'll get a report on like where I stand on the bell curve for opiates prescribed and some things like that. But versus if you look in the US, like Kaiser Permanente, for example, right? The bigger entities, they have more of a standardized framework where they're actually looking at like, what are the admission rates of the family medicine patients to hospitals and ER visits and things like that? Like, does that bigger organization, the pharmacy, like, do they have health KPIs and metrics that they're looking at, or is it generally business focused things?
Well, I think a lot of them they're really business focused, right? Because I mean, we don't have an ability. I mean, where the HMOs in the States, they have data on all the access points and all those things and all parts of the care. We don't really have that here in Canada, and I don't know that we have the ability to really go that route. So whenever we as pharmacy want to show the value of the service, I mean, we've got to launch research projects and really try to bring economists in, and you try to figure stuff out. But the data is not readily available to just sort of on an ongoing basis be able to measure all the time. Well, what does having pharmacists offering the service and the outcomes of it, what is it saving the healthcare system, or is it successful? What are the outcomes and all those things? So it's a little, it's not that easy to get that information.
I mean, switching gears a little bit back to the IMGs thing, like where does that then fall in terms of pros, in terms of cons? Like, is that looked at favorably across the board as a solution to getting the workforce back up to snuff, or are there like some pitfalls that we got to avoid or framework that we need to put in place there?
Well, a few considerations. I think, for a lot of the pharmacists that we would get from, the countries that they're coming from, they're not necessarily countries where practice is equivalent to what it is here in Canada. So there's not always the client centricity, right? The patient centricity that we have, even the conversation with patients. Some of it's more technical in some of these countries. So it's trying to yes, they're qualified to a certain degree as far as their knowledge, but how do they apply it in providing care and having that interaction? So I think that's a little bit of a concern to a certain degree. I think there's a realization as well that you're not going to be able to fill all your needs through the IPG pipeline. It's just not realistic. But we're also not producing enough pharmacists in Canada. So ultimately, I think there's a realization that things are going to get worse, and how we're going to deal with it. So I think there needs to be a little bit, we need to look at other solutions, either opening new schools, new seats at the existing schools, more technology. We're still using fax machines in pharmacies, right?
Same.
Yeah, you guys faxing us. So, I mean, I think there's opportunity for, and look, some retailers are going down that path of, technology, automation, that kind of stuff. But I think using technology has been slow in pharmacy. So I think there needs to be a greater push more quickly that way.
Where does Canada stack up in terms of that education for the pharmacists? Like in other countries or most places around the world, is it like a full degree on top of another degree, or is it quite a bit different?
No, it's often a full degree. Now, in Canada, it's not necessarily on top of another degree either. So, I mean, it's usually with a few years of science. I think every school now in Canada has gone to a PharmD. So it's not even a bachelor's degree. It's an advanced degree. But I think, not just the education, but the practice is different. And, in my research, I got the sense that Canada feels, and I'm not an academic, and I haven't really delved into that level, but there's a sense that pharmacy is more advanced in Canada than in most other countries, or at least in, a lot of other countries. And I get the sense that medicine feels the same way about medicine in Canada as well. So whether that's true or not, I don't know.
We're up on our little podium thinking we're pretty cool. I think we are pretty cool, though.
And that's the pharmacist think too, that we're pretty cool. But I don't know enough to know if that's true or not. I think we're probably fairly similar to a lot of the like countries, Australia, the UK, Ireland, those kinds of places. But I think there's probably a gap with a lot of the other countries where we're getting most of the IPGs from. So, I think, I forget your question now. I know, I started on education path and the different
pitfalls in the IPG route. Yeah.
Yeah. Well, I think it's just the fact that we're competing with everybody else.
Yeah.
Right. And we have one system, right? Sorry. We have 10 pathways, but each pathway has only one system. So regardless of where you're from, if you're coming to New Brunswick, you're going to go through all the same paces. Right. So I don't care if you're from India, from Egypt, from the United States, from the UK, or from Zimbabwe. If you're an IPG come from one of those countries, the requirements are all the same.
Yeah.
Right. There's no individualization. There's no alternative pathway. There's no fast tracking for people from the UK or anything like that. It's all, we're treating everybody the same.
Well, and then you mentioned something interesting with the PharmD degree. What role has that played in the change over the last few years? Like talking to a pharmacist here at the U of A in Alberta when this first rolled out, it sounds like it was somewhat arbitrary. They kind of just like picked a cutoff, and certain percent of the top performers in the class got denoted with this PharmD degree versus everyone else had their same pharmacy degree. Like what's the...
I hadn't heard that. That seems a little sketchy. That seems a little strange.
Maybe that's not 100% accurate as well, but that's what I was relayed.
They're all officially now offering PharmD degrees, right? So it's the same for everybody. So, we talked earlier about the regulators and the educators and everybody sort of getting along and trying to move. This seems to be an evolution. I think that's really likely been driven by the educators more than anybody else, right? I don't know that, and I'm not saying it's not good or it's not a natural evolution. I think just, I think just the knowledge and scholarship of pharmacy keeps increasing, and then to a point where it became a PharmD. The entry requirements in every province are still a bachelor's degree, right?
So what's the intent of the new PharmD degree then versus their standard pharmacy degree? Is it just like a modernized curriculum and the idea is that everybody does that same thing, or is it like an actual different trajectory that you can go on?
No, it's a modernized curriculum, and I mean that's eventually it'll be the only pharmacy degree available in Canada.
Okay.
It's not, while our legislation doesn't require a PharmD degree, that's essentially all you're going to be able to get in Canada anyway, right? So that'll become the standard. I mean, it is becoming the standard, and that's what it is. I think there's a greater emphasis on internships, during the program versus just through summer employment, through summer placements, and those things. So I think there's greater clinical focus. Again, that's where pharmacy is going, is offering that clinical care. And I think we're going to continue to go that way. And, I guess eat more of the doctor's lunches, right?
Well, it makes sense, right? Like changing and revitalizing the education. Like in medicine, there's a lot of rumbling going on about moving family medicine to a 3-year residency program. And that's obviously been met with a lot of mixed reviews. But just in terms of catching up with the world and technology and like the new kind of team-based primary care model, it does make sense. Obviously, it's going to be a little bit of a growing pain there, but it's good to see that the pharmacy space is already on top of this and modernizing their education system across the board, which is really cool to see.
Yeah, it's evolving. It's evolving. I mean, for me, what I find interesting is the balance or the discrepancy that you have throughout. You might walk into a pharmacy and have 3 different pharmacists with 3 totally different educational backgrounds, right? So maybe somebody was educated in Egypt, and you've got somebody mid-career like me, perhaps would have a Bachelor of Science, and then you've got a brand new graduate that would have a PharmD. So I mean, you've got quite a range there of what's there, and I suppose it's the same for any profession. As you continue to evolve, there's always some people that are have the more up on the newer knowledge and technology and all those things.
What has been the technical revolution in the pharmacy world? Like, is there a lot of things happening? It sounds like you guys are still on the same fax machines. Like the InfoWay, Canada Health InfoWay. What do you know about their Prescribe IT system, or Prescribe It? Sorry, I'm probably saying it wrong there.
Yeah. Well, yeah.
Has that been a big hit with the pharmacy community? Is it making everyone's lives easier and been wonderful?
So I don't know firsthand what the experience is. It took a long time to get going, honestly. And I was in my previous role when that sort of started, and there was resistance and there was a lot of stuff, and I think it's moving forward. I don't think that all pharmacies and all physicians are in this yet, right? So until you have everybody through these systems, there's benefit and there's not. There was issue back then with some of the pharmacies not wanting to do it because they had to pay for the transaction, or the transmission of the prescription. It's like, well, why is pharmacy always paying for these things? Why don't doctors pay for this? And it's like, well, and it wasn't our decision anyway. But you think, really, if I'm a pharmacist, if I'm a business owner, and I can get something, the data entry right into my system for a nickel versus having to pay Sam to do it in 5 minutes. I'm probably better off just paying a transmission fee and getting into my system and save there. So I think some of that reluctance to really get on to the technology and sort of embrace it, I think is hurting pharmacy a little bit. But I think there's also progress being made with some centralization. So I think there's central fill. I don't know if you're familiar with that term, but you might have,
what is that?
Yeah, so you might have a central pharmacy, so a retailer that might have. I'm going to pick on Ontario because Ontario's got lots of stores. So let's say Ontario's got 100 stores of the same under the same retail banner or corporate banner, what have you. you could have central fill where there's a central location where there's, through robotics or and technicians or assistants, you might fill a lot of the standard prescriptions that are filled at the stores, and then they're just sort of shipped to the stores for pickup.
Right. You just put a name and a label on it at that point. Is that the idea?
Right. And I think exactly, and I think so. I think it's even gone beyond that now, where the prescriptions sometimes are fed directly from the store to the central fill place, perhaps, and they're actually labeled there, and they're shipped to the store automatically.
It's like the Jeff Bezos model, then, almost, like, just with the really fancy supply chain.
Amazon Pharmacy, if it ever gets here, is going to be interesting as well. I know they've been in the States for a little bit. I don't know how well it's working, but I know they've been there. So
I heard a lot of buzz about that. That was maybe a year or two ago, and then they spent $100 million or something acquiring a chain of pharmacies, and then I didn't really hear much after that. I don't know if I'm assuming it's going well. It's Amazon; they're taking over the whole world.
Well, you know what I've heard since then, just in bits and spurts, what I've heard seem to be, they've laid off people, or they've shut down this branch of it or whatever. So they think, oh, well, maybe it's not really picking up as much as they thought. But anyway.
But yeah, the Prescribe IT thing, it's basically growing a two-sided network. Same thing we're doing here with Cherry Health, trying to get all the clinics and all the healthcare practitioners on there, right? It's like a really difficult problem to solve, and the local regional effects, the interplay. And so, like, I myself have never used the system because it's not compatible with the EMR that we're using at the clinic, but the idea of it in general sounds like progress, right?
Well, the idea is good, but the execution is difficult, and it's not just because pharmacists aren't embracing technology. I mean, there's a struggle with physicians embracing technology. I know when I go see my physician, everything's still paper. I don't know that he does a whole lot on a computer or a tablet or anything, right? So I don't know if he's got an EMR. He's using the fax machine. He's doing those things. He's got a file about that thick or whatever, and that's what it is. So. And when they do make a decision to have an EMR, they're not all the same throughout the province, and so they're not all compatible with whatever Prescribe IT is trying to do. So it's it is complicated. When I had my pharmacies, and this was a long time ago, you had some physicians that thought that they were being modern, and they had an EMR, and they thought they were transmitting secure prescriptions to my fax machine from their EMR. It's like, well, no, not really. It doesn't work that way. So, and these wouldn't be signed. So you have to sort of track back and try to make them understand that it didn't meet the requirements. So.
I thought the fax machine was the God's gift to humanity. Like, it was secure and perfect. You're saying that it's not, in fact, like a secure system?
No, it's not a secure system. If I'm getting a fax prescription from you that's fully handwritten with your signature, and I'm familiar with your signature, and I know that there's the likelihood that it's a valid prescription, that it's good, and it's coming from you, is probably pretty high, right? And if it's for something like Altace or whatever, I mean, I'm probably not going to have an issue with it.
Yeah, no red flags blinking.
600 dilaudid 8, I might ask a couple questions, or I might circle back if it's defined with an X or something. But the issue is that you've got an EMR that it's not meant to interact with the fax machine. There's no real technology in the fax machine to interact with that kind of secure system to really validate something. And the EMRs don't provide a real signature, right? So most of them, I shouldn't say they don't. Most of them don't, or at least didn't at that time. And so they would have picked a picture of a signature, right? Well, that's like a stamp, right? When it comes through a fax machine, it's not valid. If I get a prescription for 600 dilaudid 8 milligrams from Jordan with the stamp of your signature.
Yeah, now you got some authenticity on it.
I'm not filling that.
That's funny. While we're pooping on the fax machine, that just reminds me, like, back when we were probably like 10, I want to say, maybe 7, my mom had a fax machine, and this thing would, I don't know, routinely every week get inbounds from the local medical clinic, just like that had been wrongly addressed. Like, I think her fax number was one off from whatever the clinic down the street was. And so, I mean, any system's only as good as its users, I guess, right?
Of course. Yeah.
Yeah. So beforehand, you were mentioning you've been working on or privy to some information. The governments and the regulatory bodies are now looking at people with dual roles, people that are both on the advocacy side of things and on the regulatory side of things. And it sounds like they're trying to put in more umbrella framework about kind of like separating the church and the state, for what roles an individual can have. Is that correct?
Yeah, I'm not sure where I mentioned that. Certainly, there are some provinces that are actively trying to separate the regulator from the advocacy body. And I think, from a governance perspective, I think that's a best practice. And I think it's, most of the world, most of our world that we know, tries to follow that. But there are still a lot of organizations there are still some organizations that still have a dual role of advocacy and regulation. And, it's a little bit, the interests of the professional and of the public don't always conflict. Often they're the same, but there's likely going to be some occasion where they do conflict. And when you've got a dual role, it becomes difficult to fulfill both interests very well. Right.
So that's not on the individual person. That's on like the organizational level then.
Yeah. I'm from a governance perspective. Right. So, I know in Alberta, actually where you are, I think it was only last year perhaps that government dictated that colleges or regulatory bodies could no longer hold the advocacy role either. So I think the College of Nurses in Alberta previously, or it was a nurses association, but they did the regulatory and the advocacy, and they were forced to separate. So
that's not standard in all professions. Because I figured that was pretty common across the board. Like we've got the college, and then that's like the regulatory body, right? They're not the doctor's friend. They're there to protect the public and make sure we're behaving. And then we've got the medical association. That's more of like the interest group trying to advocate. And so that's not how all the different healthcare professions or how pharmacies work.
Well, that's the trend. And in pharmacy, it's throughout Canada, it's all separate. But there are some professions, and sometimes it's just because the group is so small, right? The group is so small, and they really can't staff both an association and a regulator. And traditionally, we all used to be joined, right? So as pharmacists, when I graduated, I think we were just separating at that time, and I'm not going to say how long ago that was, but there's still some small organizations that came to being with an association mandate, and then evolved into having the regulatory mandate, but never really let go of the association mandate too. So they've got both, and there's probably not a big enough body of registrants to actually sustain both an association and a regulator. So in your province in Alberta, the government mandated that, you can't do both roles well. We certainly don't want our regulators trying to promote professions or the professionals. And negotiation and all that stuff is difficult as well. So they mandated separation of church and state there.
I mean, just looking at it at the face value, it makes sense. Apart from the, just size limitations and having the manpower and the cash to support having two organizations, is there any other good reasons to not have them split up? It seems reasonable.
Yeah, I think it seems very reasonable. I think it's the right thing to do. And I think a profession is well served by having both a strong regulator and both a strong association. And I don't think you can have a super strong association when your primary role is that of a regulator.
Gotcha. And
it's a really fine line to walk.
And so what is the standard with the College of Pharmacies and professional pharmacy associations right now? Are all the provinces currently split up with that structure then?
We are, yeah.
Okay, gotcha.
Yeah. Most of the bigger professions are, although that said, the nurses have just started splitting, nurses associations, and they were big. If you want to talk about manpower, they've got the resources to have well-staffed and well-stocked associations and regulators, and they still, in many cases, were joint. But they've separated. And I know here in New Brunswick, I think they just separated not that long ago. I think Alberta just separated. So I think there are other places, but it's, sometimes when I talk about some of the other colleges I might have worked with, so say massage therapists or dietitians or dental hygienists, they may not have a whole lot, and they may not have even existed for that long as far as a profession or as far as even a regulatory body. So they often have a dual role.
It makes total sense, I guess, right? Especially on the nurses side of things, right? There's 500,000 or not, 600,000 of them. Like, yeah, that's a force to be reckoned with that union for sure.
Yeah, they don't need to be together.
Yeah. What else is going on in the pharmacy space? Like, what other kind of like challenges or hot button issues is everyone facing that like we with our blinders on in the medical world might be oblivious to? What's been going on lately?
I don't know that, you've covered a lot of ground in this conversation, and we've talked about some of those things. I think, what's going to be interesting going forward is seeing how the professions work together. I know that the doctors, they're not always in a great position either, right? And I've had conversations with doctors, with some of the family practitioners, where becoming a GP now or family practitioner has almost become a dirty word. Everybody wants to go and become a specialist. And if you are a GP, and again, it's very transactional, you get paid per visit. And so you're losing the easier visits to the pharmacist or the nurse practitioner. How do you sustain a practice where all your patients are complex? So I don't think the system is working super well right now with respect to trying to reconcile some of these things. I think there needs to be changes, and I don't know what the system is like, but we tend to treat sickness or illness, and we get paid for that. But are we really looking at trying to keep people healthy? So I don't know. I think there's room for growth in our healthcare system. I don't know what the solution is, but I sometimes feel like it should be just imploded and started over. And no government. And
revolution, burn it down, start again.
No government's going to do that, though, right?
No. Well, I mean, we're seeing a shift now towards precision medicine, right? So more genomics based. It's still like pretty early on. We don't really see a whole lot of it actually within our like medical education, but it's really picking up and taking off in the States now. And so Canada's starting to follow suit. We were talking with a few doctors last night, actually. Really good conversation just on that future of precision medicine and that exact point of like promoting health as opposed to that, we're very in Western medicine reactive, treating disease as opposed to promoting health and making that shift. And then to your other point about just needing to play nicely with all the different providers. I mean, the issue of we've had an internal debate on this, right? Even within the medical field, right? Like the walk-in clinics creaming off the, less complex, more simple patients, medication refills, the quicker things, virtual care, obviously now being like a big hot button topic in terms of, are they just at scale doing more of the same? And then of course, that's been one of the concerns then is that like, is pharmacists and then that new prescribing power, is that going to be challenging things? And so I was talking to Dr. Lawrence Lowe again from the CFPC the other day. And so that's one of the big pushes that they're making is for reform to those billing codes and that compensation structure, just to incentivize people to have those more complex patients, right? Like trying to get doctors practicing at the top of their scope because now there's a financial reason to be doing so. Yeah,
it's interesting, right? Because I mean, you pay for, here in New Brunswick, some of the experience was, you pay the physicians per visit, and some of them, or you decide on the load, the patient load that you want to have, right? And then you're compensated in as a result of that, and how often you see them. But then when you think, well, no, that's not good. Let's put physicians on a salary. Then there's a lot more time spent with patients, which sometimes is needed, sometimes is warranted, but there's less patients being seen, right? And it's easier to take a Friday off or Wednesday afternoon, right? So I don't know that the whole compensation structure is something on its own to grapple with, and how do we make sure we get the most of this so that we get the best care and also efficient care, right?
Well, is there any incentive on the government side of things? If you're fairly plugged in and working with them, like what are their thoughts on changing and reforming the compensation and the billing structure? It seems like it's somewhat slow going. Like, why do you think that may be?
I You got me on that one. I don't know. I mean, government's looking in New Brunswick here. Government's happy to be touting, big surpluses for several years in a row. But if you look at all our social programs and health and education and all those things, I mean, they're crappy. So they're happy to show, yeah, we're fiscally responsible, but the rest of us are, or the rest of society is not doing that well. So anyway, that's as far as I'll go with government.
Yeah, we could probably sit here and complain
Going
about
down.
government all day. Maybe we should just cut it there. We're coming up on our hour here.
Give me a next podcast. It'll get me going then.
Round 2. Okay, awesome. Well, Sam, thank you so much for joining me today. I really appreciate it. I learned a lot. Thank you so much.
That was a pleasure. Thanks, Jordan.